Hey guys, it's the end of week 8, block 2, and I got this sore throat. I think it's more like having a Dr. Martin in my throat. If you don't know metabolic acidosis by now, you will not do well on the KBE. So let's go ahead and cover what the physiological basis of metabolic acidosis. There's two major categories. There's the GAP and the non-GAP. So non-GAP or NAGMA, and so just got the little anion gap here. On non-GAP, there's a couple of mnemonics. The one that I thought was best because it covers all of the main things is this ABCD, and so you got Addison's, bicarb loss, chlorate excess, and drugs. So what you have with non-anion gap metabolic acidosis is you have a primary loss or primary gain. So primary loss of bicarb or gain of hydrogen ions. And what I mean by that is that you're not losing bicarb with you're not losing bicarb by combining it with a proton. You're secreting it out either through the kidneys or through the gut. And with primary gain of hydrogen, what I mean is that you're not gaining hydrogen with some other organic acid. You're just keeping hydrogen or gaining hydrogen from, well, let's just say you're not getting it from an organic anion. And hopefully you'll see what I mean in a moment. Now, first of all, I want to recommend everybody get on YouTube and watch Dr. Eric's medical lectures. I got most of this material from his lectures. They're absolutely outstanding. Better than anything I could do. So let's classify these non-GAP acidoses. So you have the main two things going on, GI problems or renal problems. And so with the GI, if you're gaining hydrogen, so this would be like someone on a feeding tube and they're just getting fed too much, and so the bacteria are breaking down proteins and stuff, and your body is absorbing the ammonium. You can also be gaining hydrogen, but it's not really gaining, it's just not excreting the amount of hydrogen that it should be in renal tubular acidosis. So you got type 1 and type 4 for a gain of hydrogen, and type 2 for a loss of bicarb. With renal failure, the thing there is you're not getting rid of ammonium, the NH4, and then hyperkalemia, we're going to go into that. And then you have these loss of bicarb problems. Main one is going to be diarrhea. So diarrhea is the #1 most common cause of non-GAP acidosis, and renal tubular acidosis is the second most common. Now, because you're a physician and you'll be prescribing, or you're going to be a physician, and you'll be prescribing people or starting people on IVs, or telling a nurse to, or doing it yourself, I don't know, but you're going to be giving people normal saline, it's important to know that you can actually cause acidosis. And here's another way to classify it, and this may be a little bit more clinically useful because it breaks down common and uncommon. And so if you have a non-GAP acidosis, metabolic acidosis, you want to look at these 4 things first. Now, these are not listed in order of common to most common. Diarrhea is most common. RTA is going to be second most common. RTA meaning renal tubular acidosis type 4. So then, what is renal tubular acidosis? Renal tubular acidosis is a defect that happens with either the exchange of bicarb, so pulling bicarb back in, or not getting rid of hydrogen. So if it happens in the collecting duct, it's called distal renal tubular acidosis. It's not in the distal tubule, it's in the collecting duct, but it's called distal. And if it's in the proximal convoluted tubule, it's called proximal, so that's easy. But you got to remember type 1 is far away, type 2 is close to the glomerulus, and then if it's aldosterone, it's type 4. Why is there not a type 3 on here? The reason is type 3 is an extremely rare genetic disorder, and it basically presents with problems in both of these areas. So a renal tubular acidosis right here, I'm going to read it to you. I know you can read, but it's a group of disorders that share these characteristics. They have a normal anion gap. There is a defect in the kidney's ability to maintain a homeostasis for acids and base, and it's in the absence of renal failure most of the time. So now you know basically the physiology. Here's the etiology. In children is going to be genetic or idiopathic. In adults, you're looking for autoimmune, drugs, and just go ahead and read these. Toluene, we're going to go through toluene in a bit. And then in RTA type 2, again, same thing, genetic disorder, idiopathic, Fanconi. So remember, type 2 is in the proximal, type 1 in the collecting duct. Type 2 usually is broken down, and it's classified whether it's an isolated, meaning only bicarb is affected, or if it's Fanconi, meaning all of the ions that should be absorbed in the proximal tubule are affected. Then with type 4, you remember renin causes the activation of angiotensinogen to angiotensin 1. Then you got angiotensin 1 being converted to angiotensin 2, and that causes aldosterone release. Now, aldosterone will cause sodium reabsorption, potassium secretion, and hydrogen secretion. So anything that gets involved in that pathway from the production of renin all the way to aldosterone acting on its site of activation can cause a type 4 RTA. So I wanted to highlight the things that I thought were important. So drugs I thought were important. Of course, ACE makes sense. ARBs makes sense. NSAIDs is not quite as overt. First thing it does is it blocks the prostaglandin release, which stimulates renin. And then the second thing it does is it has an effect on angiotensin 2 and aldosterone. So essentially it interferes with the angiotensin 2 stimulation of aldosterone. Now there's some other things they got caught off. There's all drugs. I think the only other drug was listed on here was aldosterone receptor antagonist like spironolactone. So be careful with them diuretics. A few other things that can get in the way. A bunch of different nephropathies. Addison's disease, which is an adrenal insufficiency. I don't know why. I just feel like this is going to be tested. I could be wrong. So next we got diarrhea, and most of the secretions from the gut lumen, anything below the pyloric sphincter, most of the secretions are going to be alkaline, and so you can kind of see that mechanism here. Now that can typically is okay if there's food in the GI tract, because that food is coming in with acid, and the way the acid was made in the stomach is it took the hydrogen ion from water and spit it out in the stomach, and it took the bicarb, and it spit it into the blood. So whenever food is going into here, all this stuff is coming back together and it neutralizes itself. However, whenever you got some secretory diarrhea or anything that's causing chlorine to be spit out when in fact it wouldn't be otherwise, you're also getting bicarb spit out into the lumen of the GI tract. It's always going to be a little bit alkaline, and that's going to cause you to give you acidosis. Now, kidney is, so if you got renal failure, usually it's going to be with an anion gap. The anion gap, when it occurs, will never be very large. If it's never usually ever going to be over 20. But all this is a problem getting rid of the ammonium ion, the NH4 that builds up and is supposed to be getting rid of, and you can't do it. So where does that NH4 come from in the first place? Well, it's coming from protein metabolism. So if you just have a low protein diet, it should help clear that up. When you start somebody on saline, whenever their volume depleted, there's a good chance that can cause acidosis, and the exact mechanism isn't completely understood. There's a lot of good ideas, but the important thing is to know that it reverses quickly when you stop. A ureteral diversion is somebody has a surgery to get their bladder taken out, and in that process part of their intestine will be cut, and the ureters will be inserted into that portion of the intestine, and there will be a stoma where they can drain all the liquid. And that's a really good idea, but the intestine is going to have some different kind of cells that the bladder doesn't have. And so what happens when you send something in there like chlorine or urea? So the first thing is, if you got the chlorine out here, the chloride, instead of this having to be pumped out, it's already out here and it can be pumped back in, causing bicarb to be excreted. So this is being pumped across here, the bicarb is being sent out. The second thing with urea is the bacteria get a hold of it and turn it into NH4. So whenever it's NH4, that can go across this transporter into the body and increase the body's acid. Hyperkalemia, so potassium, whenever you have a high potassium outside the cell, what it wants to do is move into the cell, and when it does, the hydrogens will move out to keep electric neutrality. Just remember, nature loves balance. If a positive charge is going in, either a negative charge needs to go in with it or another positive charge needs to come out. If that doesn't happen, you're going to start generating a polarized state, and that usually most cells, not all cells, but most cells don't really like to be too depolarized. Now the other thing that potassium can do, and I don't know if we can see it very clearly or not, is there's a potassium hydrogen exchange in the kidney, and whenever potassium in the serum is really high, is going to affect, the potassium would have to come up a concentration gradient, and so that's going to block this from happening. So that's it for the non-gap acidoses. Now let's go ahead and look at the anion gap acidoses. Let's talk about mnemonics and categorization. So I know mud piles is huge, or mud pilers, depending on if you want to include rhabdomyolysis. But in 2008, this nephrologist of the 21st century came out and said, hey, mud piles sucks, and here's a bunch of reasons why. We suggest gold marks. One of the reasons, just off the top, that mud pile sucks is, well, the P used to be paraldehyde. Paraldehyde it's not used anymore. It's not even produced in the U.S. So of course it's been replaced with propylene glycol. So that's an improvement. Another thing is isoniazid and iron are just two of many drugs that cause acidosis. Now, I don't know how this gold marks improves on that any, but we'll take a look and see if you like it better. The main reason they suggested gold mark is because there were a couple of new causes for acidosis that were not being able to be categorized in this mnemonic. One of them is oxyproline, which is a very recently discovered cause of acidosis. Another one, D-lactate, which is fairly recent as well. Now it's important also that in emergency room situations, one of the most common used mnemonics for acidosis is COLT. And that's because it covers the three most common causes of acidosis, and it also takes a look at the most typically what are the most emergency related acidoses. So someone's bleeding to death internally, lactic acidosis. So my thing is, for testing purposes, I'm going to have this one memorized. Whenever I get out into clinical practice, I'll take this one for a spin and see how it works for me. Now let's take a look at some of these causes. So I'm going to hit a whole bunch of them at once right here. Methanol, ethanol, ethylene glycol, propylene glycol. Because all of these have very, very similar physiological bases, so it all starts out with being metabolized by alcohol dehydrogenase. And so you're going to have an aldehyde being produced, and then a different, so formaldehyde dehydrogenase or aldehyde dehydrogenase will act on those to produce a carboxylic acid. Now, in the disease state, these carboxylic acids that are made by all of these poisons These are the things that are causing problems with the carboxylic acids. In the past, if somebody had any of these other alcohols ingested, ethanol has a higher affinity for alcohol dehydrogenase than the others, and so you would get a person drunk on whiskey to allow the kidneys to excrete all of these other alcohols. Now there's actually a drug that's better to be used for these poisons that will outcompete for alcohol dehydrogenase. 5-oxyproline. So if you're using acetaminophen, taking it every day, regular basis, chronic use, it's going to end up blocking glutathione. So what happens is, I'm just going to put Tylenol for short. So Tylenol is acetaminophen is going to block the production from gamma glutamylcysteine to glutathione. Now this is called the gamma glutamyl cycle. It's not something that we really looked at very closely in any type of biochem at this point so far. So I doubt it to be tested, but just in case, allow me to explain. As this step is being blocked, you get a buildup of this molecule, and then through some alternate route, it goes back to produce more of the 5-oxyproline. I cannot make an arrow to save my life. It goes back to produce more 5-oxyproline. There's some other risk factors to be aware of, so all of those will either block or slow down the production of glutathione. Now, lactic acidosis has a lot of different etiologies, but they can be grouped into just a small group of physiological causes. So, for example, we can have problems with O2 delivery, ischemia, and CO poisoning, carbon monoxide, or problems with O2 utilization, which is going to be a mitochondrial problem, or you can have a tumor that's producing lactate, increased motor activity, so when I go get my swole on, or if there's an inability of the liver or kidneys to take care of it. Now, I went ahead and put GI absorption, but that doesn't pertain to L-lactate. It pertains to D-lactic acidosis. So let's take a look at exactly what the idea is. So you have glucose in a cell. Oh, and this isn't the only place you can get. I'm going to show you where pyruvate. So it gets metabolized down to pyruvate. So it's not the only place you get pyruvate. You can get pyruvate from amino acids. You can get it from several other places as well. But for simplicity's sake, we're going to say it comes from glucose, and it has two options. It can go into it can get broken down into the TCA cycle, or it can get converted to lactate. TCA cycle takes place inside of the mitochondria, and at the very final step of substrate level phosphorylation, you have to have oxygen. If this stuff isn't working, you're not getting enough ATP, so your body diverts the buildup of pyruvate into the lactate and gets way fewer. It gets only 2 instead of 32, 34, or 36, depending on what book you read. It gets you 2 ATP, and it also will reform an NAD+, which will allow more pyruvate to be formed. You'll remember as glucose breaks down into pyruvate, NAD+ is consumed and is turned to NADH. If that kept happening, then you couldn't get glycolysis anymore. It would just stop because you had used up all of your NAD+. But this way we reform NAD+ in situations where NADH is already very high. So with those mechanisms in mind, you should be able to look through this list, and it should be very easy to understand. D-lactate is somewhat of a new thing because bowel surgeries weren't huge in them. I mean, they're getting more and more popular. People wanting to lose weight and stuff. But if you get a bowel resection or bypass, then glucose will make it to those bacteria that are in your colon. So when we use glucose, we convert it into L-lactate. When certain bacteria use it, they form it into and enantiomer D-lactate. That gets absorbed into our intestinal wall, and there's the lactic acidosis, but D-lactate instead. And this isn't going to show up in your typical L-lactate if you're measuring lactate levels. I forgot I had this slide and I drew the whole thing for you already. So here's the L-lactate, pyruvate to lactate. So I talked about renal failure already. It can present as non-GAP. It usually presents as GAP. And the reason it presents as GAP is because whenever you have renal failure, you're also not secreting other unmeasured anions like phosphate or sulfate and several others, hippurate, sulfate, urate, and hippurate. So all these other anions are usually also not getting excreted. So it's not primarily due to creating an organic acid, it's just primarily due to you're not getting rid of an acid and you're not getting rid of these unmeasured anions. Thing is, if the anion gap exceeds 20, you probably want to think of something else for your differential. This right here is how little kids get high. So keep in mind, if a kid comes in, he's high, he's euphoric, he's got a loss of inhibition. It can also present with amnesia. If toluene gets in a high concentration, it can cause slurred speech, ataxia, seizures, coma, all kinds of crazy stuff. Last thing I'm going to look at is ketoacidosis. So if you don't have enough insulin, or if insulin signaling is impaired, you're going to start releasing fatty acids from your adipocytes, and those are going to go to the liver and undergo beta oxidation. Once it undergoes beta oxidation, you're going to end up, your final product at that point will be acetyl-CoA. Acetyl-CoA, whenever it's in excess, which it will be because you don't need to be oxidizing the fats, the hormones are telling you to. So you're going to have excess acetyl-CoA. When it's in excess, you get acetoacetate, which is the only true keto acid. So acetoacetate can be enzymatically converted to beta-hydroxybutyrate, or it can spontaneously degrade into acetone. All three of these things are commonly referred to as keto acids, but however, let's take a look at this. This one is not an acid. This one is not a ketone. It's an aldehyde it's a carboxylic acid only with an alcohol on it. So here's a ketone. Here's a ketone, here is an acid, and here is an acid. Okay, I'm done with that rant. I want to point out one other thing. A lot of the assays that measure ketones in the serum or in the urine, they will not measure beta-hydroxybutyrate, and so that's important because under some conditions, the acetoacetate will be forced in the direction of beta-hydroxybutyrate, and so you'll measure a normal or moderately normal ketone, but you'll really be having a whole lot of beta-hydroxybutyrate. So depending on what assay and what method you use, you could have a false negative. So in ketoacidosis, the most popular, everybody knows it, is diabetic ketoacidosis, but it can also be caused from starvation. You're breaking down a crap ton of fats and you're releasing ketones in your serum. And you can also be this guy and have alcohol ketoacidosis. And it's caused by chronic alcoholism. The only thing I want to point out is that the alcoholism has a different mechanism than the other two that we just went through. And so what happens with that is you remember that the ethanol is converted into acetaldehyde by alcohol dehydrogenase, acetaldehyde, and then so that's done by alcohol dehydrogenase, and then this is converted into acetate. Flip that back. It's converted into acetate, and that's done by the aldehyde dehydrogenase, and then the acetate is converted into acetyl-CoA, and then from that point on, everything is the same for both things. Thing is, with alcohol, you can also you'll get ketoacidosis and lactic acidosis most often. The reason for this is through the metabolism of the alcohol, you get so from the metabolism of the alcohol, you get an excess NADH, and whenever you do that, the pyruvate is then driven. The pyruvate that you have is driven into the lactic acid cycle to restore some of the NAD plus. Alright, I love you guys. Good luck on your tests. That ends it for my last Block 2 presentation.